Hi, I'm Eric Weiner. I'm a medical oncologist and I'm the director of the Yale Cancer Center. I was ASCO president last year, and this past year I have been the chair of the board and just ended that today. The meeting, I have to say, was just a great meeting. I thought we had a great meeting last year. I thought we had perhaps the best of all meetings last year, and this year surpassed last year. One, there was a continued focus on the patient and what we do for patients. That's something we talked about last year quite a bit, but this year it very much continued, and the president, Lynn Schuchter's focus was on both high-tech care and high-touch care, and how we incorporate palliative care and approaches to patient care that emphasize the preeminence of the patient at the same time as we are pursuing cancer research and trying to make treatments better. I think that the science here was pretty dramatic. And in multiple different cancers, there were presentations that are truly practice-changing. And not just practice-changing because the new treatment is a little bit better, practice-changing because it's a lot better. In particular, there were 2 lung cancer presentations that really focus on how much progress we've made in the area of lung cancer. One was on what is called EGFR mutated lung cancer, which is a subgroup of lung cancers, where we have made just dramatic progress, and this was in patients who had what is often termed unresectable lung cancer, so it's probably not curable most of the time. But what has changed is that people can live with it for so many years with these new therapies. And then the other was in small cell lung cancer, a subtype of lung cancer that isn't the most common, but is one of the most deadly. It's almost always associated with tobacco use. We have not had any new therapy for small cell lung cancer for 2 or 3 decades. And what was shown is that the use of immunotherapy in patients who had relatively limited small cell lung cancer made a huge difference in outcome, changing both the number of patients who had recurrences, but also overall survival. And that's one where it's immediately practice-changing. And then I think there was something that's worth paying some attention to, which was a presentation that focused on using telehealth to deliver palliative care. It was on the plenary session. It was a very interesting presentation, but the bottom line is that it demonstrated that telehealth can be very effective in delivering palliative care. And during the pandemic, we used telehealth a great deal. Sadly, we've stepped back from it a little bit. But I think it emphasizes that we really need to bring the care to where the patient is more and more often, and that there are many different types of treatment, not just palliative care, but other treatments, that sometimes patients have to come to the clinic or the hospital. But sometimes a telehealth visit is fine, and we need to really use that more so that we can expand the ways we have to take care of patients. I do want to make one other very important point, which is that we're making huge strides in many cancers. There are some where we haven't, and we clearly need to work more. But where we need to pay a lot of attention is delivering that treatment to everyone. We know we have huge inequalities in the delivery of healthcare in the United States and around the world. And a new treatment that can be curative doesn't do any good if people can't get it. And that is something we're going to have to focus on a great deal, because if in fact we're going to decrease cancer mortality by 50% in the next 25 years, as called for by the National Cancer Action Plan, then much of that has to be about not just coming up with better therapies, but delivering the therapies we have now and will develop in the next 25 years to everyone.
Hi, I'm Dr. Julie Gralow. I'm the Chief Medical Officer and Executive Vice President for the American Society of Clinical Oncology. I'm here in Chicago at ASCO's 60th annual meeting. We had just announced our final registration numbers are record-setting. Over 45,000 people have registered for this conference. We had 5,000 abstracts are going to be presented, either published or presented in posters or oral sessions at this meeting, and that's also a record. The overall meeting themes, the themes of the abstracts, fall into a few different buckets. We had some discussion of application of new technologies, a great abstract using AI, a bot, to help get people to come in for their colonoscopy appointments. We had a couple of abstracts on prevention and early detection. I loved an abstract on the impact of the HPV vaccination in the United States. What it showed was not only what we've seen in other parts of the world, but really have not seen a lot of data on yet, is that in females, it's reducing cervical cancer, but we're also seeing, and this is important in terms of who we are recommending vaccination to, in males, we're already seeing in the United States a reduction in other HPV-related cancers, particularly head and neck cancer. So vaccinate boys and girls is the message here, and we really are already showing that we are reducing HPV-related cancers. And then, of course, a big theme was targeted therapies, immunotherapies, new therapies. And we had plenary abstracts along these lines and some other great abstracts looking at antibody drug conjugates, for example, trastuzumab deruxtecan in breast cancer. And actually, this trial, the Destiny Breast 06 trial, is disrupting how we think of scoring HER2 now. We have a HER2 ultra low category that we used to call 0. And these were patients who had had several lines of endocrine therapy. Now we're about to move on to chemo. The randomization was between treatment of physician's choice, what type of chemo they wanted, versus trastuzumab deruxtecan as a single agent. Remember, these are hormone receptor positive, classically HER2 negative, which means they were either 2+ FISH negative, 1+, but also they took HER2 0 that had at least some faint membrane staining, but in less than 10% of the cells. So they called that the HER2 ultra low category. And what they showed was that trastuzumab deruxtecan, this antibody drug conjugate, was superior to standard chemotherapy in terms of progression-free survival. And the benefit was seen in both the what we call HER2 low, as well as this ultra low. It wasn't powered to separately look at the ultra low, but the response rates, all the trends are the same. I think what the future holds is we're going to better understand antibody drug conjugates, bispecific antibodies, how we manipulate the immune system. Big interest in cancer vaccines here. We certainly have our cellular therapies that we're trying to learn how to best use and harness and what populations. So I think the immunotherapy and use of our own immune systems is going to be, it's the subject of many ongoing trials, but it'll be the theme of next year's annual meeting as well.